Okay, shall we kick things off?
Yes, please. Awesome.
Okay. Hi, everyone. Thank you for joining us tonight. I'm Marcus. I'm one of the registrars. And tonight we'll be having a quick chat about septic arthritis and company. A few take-home points that I just want to highlight off the bat. Septic arthritis and other bone and joint infections typically has staph as the most common organism. Please remember it, please consider it, and whenever you're treating a patient like this, please cover for it. If you unfortunately have a patient who's presented with a chronic condition and something like an osteomyelitis, remember that this is a difficult to treat condition and it often relies on culture or biopsy directed, often extended antibiotic regimes. And surgery might also play a significant role. And whatever you do, please don't miss the underlying condition that landed the patient up in this position in the first place. Typically, bone and joint infections follow a bimodal distribution, and it's the young and then people that get onto 50s and older. And this is typically because of their uh, comorbidities and other conditions that come with age. We also know that certain patients are at higher risk because of their exposures, their occupation, and their uh, other comorbidities. And we know that boys are probably affected more than girls. I think it's just because of what we get up to. In sub-Saharan Africa, unfortunately, we do have a high incidence as compared to the rest of the world. We do also interestingly know that the tibia is the most commonly affected bone, up to a third of cases, 30%. We also know that unfortunately we suffer from higher burden patients who suffer from sickle cell disease, peripheral vascular disease, diabetes, and we also have social factors to take into account. Patients have malnourishment, poor education and screening, not as readily accessible transport, and this leads to delayed presentations. But let's jump straight into the pathophys. Septic arthritis is usually hematogenous in origin. Obviously, it can follow a direct inoculation or local spread. And the reason why the joint is so susceptible is because the synovial membrane lacks basement membrane. So this makes it ideal for pathogens to seed there and eventually invade. And once the joint space is involved, you have increased synovial fluid production. And this ultimately leads to cartilage destruction. And this is from the synovial cells themselves, as well as the bacteria and their toxins. The smallest bacterial load can produce a profound inflammatory response. And what's tricky is down the line, these pathogens can be cleared from the synovium, but you still sit with the effusion. You might end up tapping this and getting a sterile inflammatory aspirate. We'll talk about tapping the joint later. Please remember, if you do have a patient with a joint effusion, that it is very unlikely to be as a result of a periarticular disease. In other words, bursitis, tendinitis, and that sort of thing should not give you a joint effusion. So think septic arthritis. Obviously, the patients at risk are those that we see in the ED commonly. If you go reading on the subject, Neisseria and gonococcal septic arthritis will come up frequently. This, however, is not the case in our setting, or at least not to the degree that they describe. We, however, see patients with HIV and other immune compromised states, and please don't forget diabetes and rheumatoid arthritis. We also see patients in both public and state sector who are post-joint surgery. And we all know that the IV drug user essentially is there to humble all of us. Now, how do they present? Classically, the teaching is that of an acute, painful, swollen limb. And I was led to believe as an undergrad that fever was basically a hallmark. But based on the literature, it's not. Hematogenous spread usually is monoarticular, although it can be polyarticular. And certain joints are more classically assigned to certain age groups. Please remember that it might not always be as straightforward as a painful joint. And in your pediatric population specifically, this has to be included in your diff for someone who's unwilling to move or bear weight. Unfortunately, patients can also present in the extremis. And this does not just include septic shock, but things like necrotizing fasciitis, chronically joint destruction, and osteomyelitis. Please, please, please never forget TB. Now, since we mentioned shock, let's talk about toxic shock. This also occurs in extremes of age, classically from staph aureus as well as strep pyogenes, but a lot of other species have been implicated. In the 1980s, because of the exotoxin produced by staph aureus, and back then the way tampons were manufactured, this was strongly associated with menstruation. I'm sure a lot of people have heard of this, but since then we've become a bit more wiser and the manufacturing process has changed and it is no longer the case. Just important to put that out there. This is a clinical diagnosis, and probably what would distinguish this from, let's say, just a septic shock is probably the rash. Patients can present very vaguely though, and because there's a large overlap with this condition and similar ones, it's often attributed to other disease processes. Now, if you're fortunate and you actually see the rash, it's classically described as being sunburn-like. Obviously not as easy to tell in our African population. So you're going to have to go looking for other mucosal involvement. And in the picture at the top, you can see the conjunctivitis, it might be pharyngitis. And if you're fortunate and you see a strawberry tongue, hooray. But often it might be obscure and something occult, like per se a vaginitis. The rash comes and goes and is typically followed by desquamation, but please note that this is a delayed finding. If you wait for this to make your diagnosis, you've missed the boat. Strep is often a more deep-seated infective process than staph, so it probably has a worse outcome. And what's interesting to distinguish the two is staph is toxin-driven, so you only need a small infective focus, but the toxin released to get a very sick patient versus strep relies on the infective process itself. Now, what makes all of this so devastating? Superantigen production. And this is produced directly by those strains. And what they do is they skip a step and bypass your normal antigen-mediated immune response, basically leading to uncontrolled an immune response with release of T cells and cytokines. Now, we don't see this as often because most of us have antibodies, but a large or rather significant portion of us don't. So please think about it. But don't use this clinical decision criteria or diagnostic criteria rather. It's there and you should know about it. But it was derived in very light-skinned individuals. It was research focused. It hasn't been validated. Basically, what I'm trying to tell you is that this requires a very high index of suspicion and definitely good clinical judgment. And now that you've started working up your patient, we have to talk about imaging. An X-ray is always going to be our first line. But you're not going to see the pus in the joint. You're going to see subtle, probably secondary findings, joint space widening, erosive changes. And who am I as an EM reg if I don't bring ultrasound into the discussion? This is going to help you look for joint effusions and also guide your aspiration. Bearing in mind that you may require more advanced imaging to look at more difficult to access sites. Here we have an X-ray. This is an AP pelvis of a pediatric patient. And I hope everyone can appreciate the joint space widening as compared to the opposite side. And you can also see early epiphyseal destruction. Now, if you went and put a probe over that, you might be fortunate and actually see the joint effusion. That anechoic area also extends into the joint if you see between acetabulum and head of femur. You might also see debris, or it might look like a complex fluid collection. And if you put color Doppler over the membrane, you might see hyperemia. And I'll show you an example later on. Now, we spoke about looking for the effusion, but also tapping it. And joint aspiration is, after all, the gold standard for diagnosis. Ideally, you should be doing this before giving antibiotics, but obviously this depends. If you have a patient in extremis and septic shock, please resuscitate them like you would under normal circumstances with good resuscitative measures, fluids, inotropes, steroids, and the like, broad spectrum antibiotics. Once you have the aspirate, please send it off for white cells, gram stain analysis and culture, bearing in mind that they might be negative, specifically in certain conditions that are notorious for this, like TB and Neisseria, but you're also there to rule out other differentials. And I want to ask the crowd here, can anyone think of a very close mimicker, a differential for an acutely painful effused joint?
So a hemothrosis?
Hemothriosis. And in a patient that is appearing, it's got pyrexia or erythema involved.
No, I don't know.
Gout, but maybe not in
Gout, absolutely. Absolutely, yeah. You have to think about gout and pseudo-gout. And aspiration is going to help you distinguish the two. In gout, you're going to see monosodium urate, and in pseudo-gout, you're going to see calcium pyrophosphate. But please remember that patients who suffer from gout are at higher risk for developing septic arthritis. So just because you see crystals doesn't mean you've excluded a septic arthritis, and vice versa. Now, this is a picture of a joint infiltration. If you're going to do a joint aspiration, please remember it is a sterile procedure. So in other words, that knee needs to be skin prepped, properly draped, sterile gloves, sterile probe cover. And on the picture on the right, you'll see there the needle in that effusion. Now, once you've done this and you've started treating the patient, like I said, you're going to start with broad spectrum antibiotics. And in Gauteng, or rather in Johannesburg, our biogram suggests that Augmentin is a very reasonable first-line agent. But this means nothing if you're not going to get source control. This is, after all, an orthopedic emergency. These patients need arthrotomy ASAP. Certain patients might be selected for needle aspirations, but these are typically patients that are poor anesthetic candidates, and this is not a decision that you should be pushing for in the ED. Leave that up to the anesthetist and the orthopod. Once you do have a culture, please target your antibiotics and de-escalate appropriately. And if your patient's so unfortunate to end up in septic shock, don't forget your clindamycin. This helps with decreasing the toxin production. And if they're in shock requiring inotropes, don't forget steroids. Now, what I like to read about this, and it makes perfect sense, but I didn't know about it, is toxic shock obviously is super antigen mediated, and most of us have antibodies. If you don't, you can treat them with IVIG. If you read about this, obviously in the States, MRSA is a much bigger problem than it is here, especially community acquired. So we're not going to empirically cover for it, but if you do get a culture, please don't forget your Vanco. And if you're thinking gram-negative, remember your Tazocin. Unfortunately, there's no set duration of treatment. This is all going to depend on blood cultures that are repeated, response to treatment, both clinically and biochemically. And in certain cases, like fungal involvement, you may have to extend to even up to 2 weeks after your last negative culture. Hopefully, this will not be happening in the ED, though. So as we move on, a quick little guessing game. Anyone want to take a wager what species this bone belongs to? Anyone?
Dinosaur.
Good guess. It's a T-Rex fibula.
Yes.
So this is one of the oldest examples that we have of osteomyelitis. It is literally a disease as old as time. It was described by Hippocrates and was actually already published about in the 18th century. Now, what's interesting about this is that this disease has dictated many surgical principles in terms of debridement that still hold true today, because before penicillin, it was the only therapeutic option. So let's talk about osteomyelitis. Now, if you think about septic arthritis as an outside-in process, I like to think about osteomyelitis as an inside-out process because it's all dependent on the blood supply. You have these vascular loops, microbes deposit, phagocytes, inflammation, pus formation, obstruction of flow, compromised flow, increased intramedullary pressure, and the cycle just perpetuates. You end up with bone ischemia and necrosis, and this will ultimately lead to the sequestrum and involucrum, and we'll talk about that a little bit later again. And if this pus ends up rupturing through the periosteum, it might involve local structures. If it eventually reaches the skin, this then gives us the classic sinus tract. You also have to talk about it in terms of its etiology, hematogenous, contiguous, or via direct inoculation. And if you have a contiguous spread, please don't forget vascular insufficiency. They actually mention this specifically in the literature. You can also classify it based on its acuity. Please don't ask me what it is. If it's 3 weeks, nowhere could explain that to me. Now, when you talk about kids, hematogenous is usually the most common etiological cause. In adults, contiguous, probably because of what we do, our hobbies, our vocations, and also, unfortunately, our immobile patients with pressure sores. If you do have an adult with hematogenous osteomyelitis, it usually goes to the vertebra. And that's probably because the blood supply is very similar to that of long bones. Don't forget peripheral vascular disease and diabetes, because these put these patients at higher risk and also make it more difficult to treat. There are also specific subsets and pediatric presentations, the subacute and the chronic recurrent multifocal. Unfortunately, the chronic recurrent multifocal is probably associated with psoriasis and other autoimmune disorders and is not infective. Now, let's say you have this patient in front of you. These pictures make it pretty obvious, but it might not always be the case. They might present with very vague symptoms, fever, rigors, and if you're lucky, they might localize a bone or a joint. In your kids, once again, include this in your diff for someone who's unwilling to walk. And unfortunately, constitutional symptoms are not consistent or reliable, especially when it comes to including or excluding this disease. If they do appear quite toxic and sick, please don't attribute this to the osteomyelitis. It's more likely something more acute. Always think septic arthritis in this case. Now, if they end up to have chronic osteomyelitis, you will see this pathognomonic sinus tract, and it might be as small and as subtle as the picture above, or as glaringly obvious as the one below. And you might even clinically be able to palpate the involucrum and sequestrum. These patients tend not to be as systemically ill. And like I said, their presentation can be very vague. Don't forget that patients who've had surgery to 12 weeks can present with a direct inoculation osteomyelitis. And if it's after that, it's typically not related to the surgery, more likely hematogenous spread. Now, I've never done this, but this is discussed in many of the articles and texts that I read. The probe to bone test is when you use a sterile metal instrument and you insert it into the tract. And if you feel the sensation of bone, it's actually quite useful in diagnosing osteomyelitis. Please just don't cause pain whilst doing this. There is a classification, and honestly, I don't think this is of use to us in the ED, but it's important to know that it's there because the orthopods are going to use it, and it most likely is there to guide their surgical management down the line. This is just to illustrate that certain patients are at risk more of developing osteomyelitis in certain sites. Not surprisingly, diabetics will have foot ulcers. But what I found interesting is that patients with dialysis, and I think this is more likely in the permacath population, they might have osteomyelitis of their ribs. And like I said earlier, IV drug users can present with anything. Please don't forget TB, especially with the spinal involvement. There are other risk factors that we haven't discussed up until this point that you must never forget, and this is any immune-compromised state, including those with chronic steroid use, patients with endocarditis, and in Africa we have an entity called the Buruli ulcer, and it's caused by Mycobacterium ulcerans. Just thought that's interesting. Complications, like we said, depending on where the pus spreads and or ruptures to, you can think of any kind of complication. The most feared one, I would argue, is systemic involvement, bacteremia, and septic shock. Now, you can also have osteomyelitis in very strange sites, like the face and skull, or cervical vertebra. And if you have cyst formation related to those can obviously be devastating. You have to think about rib osteomyelitis leading to an empyema, vertebral involvement leading to cord compression. Also think in your pediatric population about growth plates, deformity, failure to thrive. Unfortunately, a lot of patients present with pathological fractures. And speaking of fractures, let's talk about x-rays in this case. Also our first line, but please bear in mind that because the disease process needs bone mineral loss to manifest on the x-ray, you might miss this for up to the first 2 weeks. So we're also going to look for indirect, non-specific, and often subtle findings like soft tissue swelling, periosteal reactions, osteopenia, and such. If you do end up seeing involucrum and sequestrum, it's pathognomonic. But please look for differentials. The patient can present still with fractures, with bone tumors, with METs, with other arthritides and other joint disorders. Moving on, if you're so fortunate to have MRI, with gadolinium is your study of choice. You can look at early disease changes, and if negative, can basically exclude the disease. But most of us, besides X-ray, will probably have CT as your next go-to. Now, it suffers from the same limitations, especially when it comes to hardware. But, like we said before, it can image more deeper and obscure structures. Now, if you have a patient that clinically and based on history, you're convinced has it, and you refer them, the orthopods might consider sending them for bone scanning, even with the x-rays being normal, because it's very sensitive for early disease. And it's also useful in the setting of hardware. However, it's got a high radiation burden, time consuming, and it's not something we are going to readily access after hours. And this is where ultrasound comes in. Anyway, here's an x-ray. This is an example of osteomyelitis of the 5th digit of the metatarsal. And let me just see if my pointer can work here. Here we can see bony destruction. Here we can see a periosteal reaction. Please note that this digit is massively swollen and probably tender. And look at the relative osteopenia here when you compare it to its neighboring phalanx. Can everyone see that? Please just let me know that the pointer is working.
Working, and yes.
Great. Okay. Here we have sequestrum, which is just necrotic bone, and then involucrum, which is disorganized new latticed bonework. And the left shows a CT image and the right shows an X-ray. In a more chronic condition, you might have something called a Brody's abscess, which is essentially just a bone abscess. And now this was an interesting trick. If a patient has a digit or an appendage that is so tender that they can't tolerate direct pressure, you can put them in a water bath, because the water is going to transmit the sonar waves pretty well. You can also use a glove like top right. And the image you'll get is top middle. And if you're so lucky, you might actually see at the top the periosteal elevation, like this here. And then if you put color on it, you might end up seeing hyperemia as compared to other sites. Pretty cool. Now, if you go down the reading rabbit hole of workup, you're going to come across the Koch criteria. It's ancient. It was derived to work up patients, specifically pediatric patients with septic arthritis of the hip. It still uses fever, non-weight bearing, ESR, and the white cell count. We have since included CRP to make this a 5-point score. And like most of our clinical decision rules, a lot of them, it's only really useful in the extremes. So if all of them are positive or all of them are negative, we have also found that the combination of ESR and CRP has greater sensitivity, so please include it. But don't use PCT as your first investigative marker. It doesn't perform as well. Most of us will hopefully get early blood cultures in an undifferentiated patient, and even if you're thinking osteomyelitis, please get them, bearing in mind that they may have low yield, but sometimes will give the only ID that you can then follow. And if this patient ends up going to the orthopods, they'll hopefully take them to theatre, and they might even do a bone biopsy or aspirate, and this will then guide our subsequent management. We do not, however, culture the skin tracts. They are polymicrobial and inaccurate. Now, I know this is a very busy slide, and whenever you read about this subject, it'll give you these population groups that are at risk for developing certain infections from certain organisms. But what's important is at the top, in bold, staph still predominates. And in our setting, please don't forget TB. Ultimately, you will need cultures to justify covering for these other anaerobes, these other organisms in our setting. But don't forget them. Now, the next two slides are probably not necessary for us in the ED, but I did find it very interesting. When you talk about staph aureus, you have to understand why this bug is this big baddie that it's made out to be. And it's with good reason, because it's got so many characteristics that make it ideal for landing up in the bone and the joint. It's got adhesions, it's got adhesins, it's got toxins, it's got so many immunoevasive factors. It can latch on to bone and its surrounding structures, collagen, sialoglycoprotein, whatever that is. It's got its own subset of adhesins called the MS grams, which make it even more suited to latching onto bone and surrounding structures. It can sit in distinct niches like abscesses and sequestra, which are obviously oxygen poor, perpetuate ischemia, necrosis, and infection. It can even be internalized by our osteoblasts into healthy bone. Even worse than that, it can incapacitate our own natural immune cells and liberate nutrients. Guys, this bug was made for bone. We mentioned that perpetual and vicious cycle. Staph releases coagulases that can actually contribute to thrombosis, hence hastening the process. It can act as a super antigen. It can interfere with T cell function. Ultimately, staph is bad. But despite all of that, it still comes back down to basic. Think about these cases, cover for them appropriately, institute good resuscitative measures and care. And then basics like wound care, nutrition, glucose. Advocate for these patients to get their surgery in a timely fashion. And if they've got a septic piece of hardware, it needs to come out. Hyperbaric oxygen is a bit of a pipe dream in our setting, but it does exist. And some of these patients might benefit from it. And always remember to address vascular insufficiency. And that, ladies and gentlemen, is my talk. Thank you so much for attending. If there are any questions, please do let me know.